Welcome back, everyone. This is the Data Improvement Track. Next up, we have Kristina Rogers presenting on the Government Performance and Results Act GPRA update. Kristina Rogers is an employee of the Nashville Area Indian Health Service and has been with them since October 2005. She is a certified clinical documentation expert for outpatient services, professional coder, biller, and auditor, as well as the AABC approved instructor. She works as the Nashville Area Statistician, GPRA Coordinator, Health Information Management Consultant, HIPAA Privacy Act Liaison, is one of the improvement advisors for the Nashville area and provides medical coding and auditing training for federal, tribal, urban locations nationwide within the Indian Health Service. Welcome, Kristina Rogers. We'll go ahead and get started.
All right, thanks, Brian.
No problem.
So today what we're going to talk about is Government Performance and Results Act. The good and the bad is that it doesn't change much. So we're just going to kind of go over some general information. We'll talk about some local system reports, and this is applicable to sites that use the EHR and RPMS. We'll talk about the logic, the national system reporting, and then just some strategies for improvement. So GPRA is a federal law. It was passed into fruition under the Clinton administration. During the Bush administration, it was transformed to have some budgetary strings. And essentially what it does is it just requires a data supported audit trail for the appropriated dollars to the activities that the agencies are doing. So essentially Congress wants to know, what are we doing with the funds that they're providing to us and how is it impacting our customers? Under the Obama administration, it was actually transformed again to basically strengthen the law. And it does now require federal agencies to use performance data to drive their decision making. So prior to the GPRA Modernization Act under the Obama administration, we used to have to report over 20 measures annually to Congress. With that change, we decreased the number down. In past years, it's just been one measure. So for 2021, and actually late breaking news, I found out for 2022, the GPRA MA measure is going to continue to be the intimate partner violence depression screening. So that is the measure that we will send to Congress on behalf of our agency. But we still are tracking a number of other measures, and those other measures have become what we call budget measures. So these are things that we're tracking to show that, again, we're utilizing the funds to help our customers. If we can show improvements to the services and the care that we're providing to our patients, there is a potential for additional funding. And we do, like I said, continue to monitor those clinical and annual targets. So GPRA is important because, again, it can potentially affect funding for tribes. If it's utilized in a way where you're using it for improvement work, it could potentially help you provide better patient care, allow for your site reports to be a little bit more reflective. Hopefully, if we are providing the care that is part of the preventive piece of GPRA, it could in turn decrease the cost of care for our patients in the long run. Federal and urban sites are required to report GPRA. Tribal sites are not required to report for GPRA. So we do appreciate everybody that does participate and does actively try to improve those measures because it can impact our overall budget. So when we talk about how GPRA is measured, essentially there are a set of measures, and every year they get reviewed by a group of experts at the headquarters level, the OMB, the Office of Management and Budget. They ultimately approve any changes to the measures. We do have some measures that we try to track on an agency level that may impact our population a little bit more than, say, the outside general population. And typically those are known as developmental measures until they become national measures. But essentially there's 4 buckets. We're tracking diabetes measures, dental measures, immunization measures, and then prevention measures as well. So for local system reports, and again, this is only applicable to RPMS EHR users only. Essentially, there is a package in the RPMS called the Clinical Reporting System. It is the same at every site. It's an automated way that we can run reports. We can get the information quickly. It is updated on an annual basis. And again, the logic for all facilities matches, so that way we can aggregate the information to see where we are as an area as a whole for those sites that utilize that system. The GIPR indicators do have one or more denominators and numerators depending on the measure. And essentially it's translated into software logic. So wherever possible, we try to use industry standard codes. So SNOMED codes, ICD-10 codes, CPT codes, LINC codes. There are some specific IHS codes that fall under health factors, dental, and patient education. So those sites that are not using RPMS EHR, those pieces of the logic are a little bit tougher for you guys to meet because they are not industry standard, they are specific to the IHS. And the CRS package, what it does is it essentially does a scavenger hunt. It looks to see, is the patient eligible for this measure? If yes, did they receive the service that this measure pertains to? And it's just going to look in all different places. It's looking in our lab taxonomies, medication taxonomies, community taxonomies, because the population for GIPRA mirrors the user population. So the patients have to have one visit in the last 3 years. They have to be American Indian Alaska Native, and they have to live in your service area, your PERKTA, in order to be counted for GIPRA. Also part of the population, if they have a date of death that is documented in your system, it takes them out of the denominators. If you inactivate a patient, but they still meet the criteria for user population, they will remain in your system until they age out of that 3-year time frame. So we always like to just do a quick little disclaimer that the CRS software, it's a solution. It's a software and not a solution. There's a saying in the IT world, garbage in, garbage out. So what we put into it is what we're going to be able to get out of it. So that's why we want to make sure that the data that's going in, the information about our patients that's going into the system is accurate, complete, and clean, so that we can pull it out and it'll actually be reflective of the services that are being provided. So in terms of involvement, it does take a team. Providers, coders, data entry, pretty much anybody that has contact with the patient, because even patient registration staff, if you list them as living somewhere other than where they actually live, and it may or may not be inside the catchment area, it could impact the numbers. We have seen this recently with some of the patients that are non-beneficiaries coming in for COVID vaccines. They were listed incorrectly in our systems and added to the denominator when they should not have been. So those are things that you need to be aware of as your team. Proper documentation of the care that's given through the EHR, accurate and complete coding, data entry if you're doing any entry of outside services, and then utilizing some type of health summary, patient list, or the forecast reports for those monitoring progress. So next I'm going to move into kind of a brief description of the logic. For 2021, we are actually tracking 26 national measures, but for 2022, it moves to 25 measures. And the reason is because the childhood weight control measure is a long-term measure. So we will report it in 2021, and then in 2022, we will track it, but we will not report it. So the next time we'll report the childhood weight control measure will be 2024, because it's every 3 years. So that's why this slide says 25. We're kind of at a weird time GIPR wise because the GIPR year ends September 30th. So I wanted to give you some information about the current year as well as the upcoming year. So we'll start with the dental measures. So again, it's user population patients, the different age ranges for dental sealants and topical fluorides, 2 to 15 and 1 to 15. And basically the system is just looking to see if they had a dental visit. Now I will say there have been some reports of people having issues with Dentrix and Dentrix sending data to RPMS So that is something that you want to monitor locally to make sure that the data is getting crossed over correctly. If you're not using an RPMS EHR, you just want to make sure that the data that you are submitting to the data warehouse does include at least one of these ADA codes or the dental billing codes or the ICD-10 codes that applies to that dental service. Next, we have diabetes measures. And one thing that I like to note about this is that people get added to this denominator only if they were diagnosed with diabetes prior to the report period. So it has to be before October 1st of that GIPR year in order for them to be counted. So if you have newly diagnosed diabetes patients that happen during the GIPR year, they will not be part of the denominator until next year. So for blood pressure control, we're looking for blood pressure that is 140/90. The patient has to meet both the diastolic and systolic values in order to actually meet that measure. And essentially what that system does is it just looks for an average of the last 3 blood pressures. Non-RPMS sites, there are some CPT codes that you can utilize to capture this in your systems as well. The nephropathy assessment is looking for a GFR and a urine albumin to creatinine ratio. They don't have to be done on the same day, but they need to both be in the system. For glycemic control, we're looking for patients that had an A1C greater than 9, but this is one of those reverse measures where we want it to be as close to 0 as possible. So if you had 60% in this, that's not great. We're hoping to have it below, I believe the target is below 16. So you want this measure to be as close to 0 as possible. For the retinopathy assessment, this is individuals that had a qualified retinal exam, could either be a diabetic retinal exam, the JVN machines work. There are some other codes that count for non-JVN, but telehealth type services. So I've listed out some of the options that are available to be counted for that particular measure. We've got the statin therapy measure for our diabetes patients. And essentially what this measure is looking for is if the patient meets the criteria for the diabetes denominator, are they on a statin or do they have some contraindication or some issue that is documented in the EHR. If they have had an adverse reaction or some contraindication to a statin in the past, that needs to be documented so that it takes them out of the denominator. But essentially, anybody who should be on a statin should have a statin documented in the system that they are on it. Outside medications count as well. So if you have a patient that sees an endocrinologist outside of your facility, you want to make sure that your records are up to date. You can enter that as an outside medication and it does count for GIPR. Next, we have everybody's favorite measure, the adult immunization. This is probably the toughest measure that we have because it has so many facets. So it's looking at patients that are 19 to 65 and older. And for different age buckets, it's looking to see, did they have specific vaccines? I can tell you that typically for the 19 to 49 age group, we're seeing that it's the Tdap or TD in the past 10 years that's missing. A lot of them have it documented as ever, but we also need it to be within 10 years. And then for our older group, it's the Zostavax or Shingrix that's typically missing. And I know that my mom especially did not want to go back for her second dose. So I think that that's something that we are going to have to continue to work with patients on to make sure they continue to get that series completed. And this one is also, it's an all or nothing measure. So for the age group, they have to meet all of the requirements for that measure in order to actually meet the measure. We also have the childhood immunizations measure. So this is looking at the patients that are 19 to 35 months old, looking to see if they had the 431-3314 combination. There are some new codes that will be added in as we get them to the logic. But again, this is an all or nothing measure. Also, the influenza vaccine Has two different groupings for the measure, the 6 months to 17 years and then 18 and older. But essentially everybody 6 months and older should be getting a flu vaccine. Next, we have Pap smears, and this is patients that are female patients that are 24 to 64 years old. One thing that has come up recently at one of our sites is for our LGBTQ community. We have had some individuals that identify as female, but biologically they are male. So they may not qualify for a Pap smear or a mammogram or some of these female related measure. And I do know that that is something that is in the works. They're trying to figure out how to take them out of the logic when those services are not appropriate. So I know that that has come up at a few of our sites recently. So I just wanted to mention that. But essentially for the Pap smear, it's looking for patients that have had a Pap smear documented in the last 3 years, or a Pap smear and an HPV DNA documented in the last 5 years. The childhood weight control measure, again, we are reporting this in 2021. This is another measure that we want it to be as close to 0 as possible. It's looking for patients that are 2 to 5 years old. The BMI, the height and weight has to be documented on the same day. And it's looking to see if they are above that 95th percentile. We also have the colorectal cancer screening. So for 2021, the age group is still 50 to 75. For 2022, they are going to change that to 45 and older, but well, I'm sorry, 45 to 75. And that corresponds with the clinical standards that recently came out. So next year for the colorectal cancer screening, the target will be baseline because the logic is changing, going down to 45. So when we start looking at the data for 2022, don't be surprised if that denominator jumps up because 5 years is a lot. You may get a ton of people added to that denominator. But for 2021, it's still we still have a target for it because they are not changing the logic until 2022. Controlling high blood pressure, this is also known as the million hearts measure, and it's looking at patients that are 18 to 85 that are diagnosed with hypertension, no history of end-stage renal disease, and no current pregnancy. And again, it's just like the diabetes measures, we're looking for a blood pressure that is 140 over 90, and both of the systolic and diastolic measures need to be met. There's a second statin therapy measure, and it basically expands the group that is eligible for it. So it's still looking at those diabetes patients, but it's also looking at patients that are 21 and older with ASCVD or an LDL that's greater than or equal to 190 or hypercholesterolemia. So again, it's looking to see if they have a statin documented in the system, if they don't have it documented, if they have a contraindication or have had an adverse effect reaction to it, that needs to be documented, and it'll take them out of the denominator as well. For depression screening, there's two measures. There's the 12 to 17-year-olds, and then there's the 18 and older. And a lot of locations are using the exam code 36 to document this. That is fine, except that the result of that, so positive, negative, I think there's a few other options. The result that you're putting in for that exam code does not get exported to the data warehouse. So we recommend either in conjunction or in lieu of using that exam code 36, you also use PHQ-2, PHQ-9, or PHQ-T as appropriate to make sure that the result of that screening gets exported to the data center. We've got the mostly exclusively breastfeeding patients. This is patients that are 30 to 394 days old who were screened as an infant for their feeding choice at the age of 2 months. So most of our clinics don't see babies. You may not see them until they're 6 months. You may not see them until they're a year. In those cases, there are ways that we can kind of trick the system. You can enter a historical or basically an old entry for that patient at 2 months. So for the RPMS EHR sites, if you are interested in that, let me know and I can send you some instructions. But typically we don't see those kids until after the 2-month period because we don't deliver babies. For sites that are using COTS products or non-EHR RPMS, you want to make sure you talk to your vendors about how that can be documented. Next, we have the HIV screening ever measure. And this is basically just looking to see patients that are 13 to 64, if they've ever received an HIV screening. I would guess that at some point this measure will evolve because it's been the same for a few years. We're really just trying to make that type of screening part of the routine screening for our patients. So next we have the intimate partner violence and domestic violence screening. As I mentioned earlier, this is our GIPRA-MA measure for 2021 and 2022. And what we're tracking is just female patients, 14 to 46. But we do know that this can happen for all ages, all genders. And so we recommend every patient, every visit, get screened for domestic violence. But for GIPRA, we are only tracking female patients. We have mammography screenings here. This is patients that are 52 to 74 years old, and it's looking to see if they had a mammogram in the last 2 years. Also have the universal alcohol screening. So this is for patients that are 9 to 75, and we're looking to see if they were screened for alcohol use. And this is another one of those measures where most people are just using that exam code 35. The result, again, does not get exported to the data warehouse. So we recommend that you, again, in conjunction or in lieu of exam code 35, you also use CAGE factor, the audit C, or CRAFT. And that becomes even more important because the result of this screening feeds the SBIRT measure. And what I've seen at a lot of places is that on the local system, they're just using exam code 35, and so it shows that they met that SBIRT measure. But at the data center, because they just use the exam code 35, it looks like they have done no screenings because you need to also use, again, the CAGE, audit C, or CRAFT in order for that result to be exported. So I mentioned the SBIRT measure stands for Screening, Brief Intervention, Referral to Treatment. It's looking at patients that are 9 to 75 that screened positive. So if you're using the CAGE, essentially anything other than 0 puts them in that positive area. Once they're positive, they need to have a brief negotiated interview, brief negotiated intervention, referral to treatment within 7 days of that positive screening. So what we see a lot of times is that patients are screened, they're not provided the education. They might be referred to behavioral health, but they don't get into behavioral health until after that 7-day time period. So we recommend that when you screen the patients, if they are positive, that you automatically provide some education to them. And there's only 2 patient education topics that count for this particular measure. And that is the alcohol and other drugs, brief negotiated intervention, or the alcohol and other drugs referral to treatment. So both of those are the only ones that count. When you pull it up in EHR, there's a whole long list, but not all of them count for this particular measure. The visit has to be an ambulatory visit. So historical entries do not count for this. And then again, if you are a non-RPMS EHR site, your COTS product, there are some CPT codes that you can utilize that will help you meet this measure as well. Next, we have the tobacco measures. So there's a tobacco use and exposure that is not a national measure. It's a developmental measure that is used to populate the national measure, which is the tobacco cessation. But essentially, we're screening patients that are 5 and older using health factor categories. You can use ICD-10 codes as well. Dental code, there's a dental code 1320 that counts for screening. And if the patients screen positive, then we're looking for some type of intervention, whether it's counseling, if they get a prescription to help them quit using tobacco products, that counts as well. And if for sites that use RPMS EHR, if the patient quit on their own, you need to make sure that you document that as a health factor because then it gives you credit for that patient quitting. So next we're going to move into talking about the national system. So prior to the change over to utilizing what's known as the ITSIS system, we used to do a manual aggregate. So sites that were not using RPMS EHR or sites that were PRC only were not included in GIPR reporting. Back in 2018, we transitioned to this new system. And essentially what it is a repository, national repository. This is where your workload data, user population data gets exported to, and it puts it into its own little warehouse known as the Integrated Data Collection System. It's a data mart that is specific to GIPR reporting. It allows us to include non-RPMS sites, PRC only sites, and then of course our federal, tribal, and urban partners. It was created so that we could include everybody, since it does have a potential impact on our funding. It was created to help reduce that burden for local sites in submitting GIPR reports, which wasn't necessarily an issue in our area because either the USET staff or myself, somebody was helping you guys with that. So you may not have even noticed a difference, but I know in a lot of other areas, it made a huge difference for them. And then the biggest thing was that it allowed our non-RPMS partners to participate in GIPR reporting. The last few years, there's been more and more sites that are pulling off of using EHR RPMS. The next few years, we'll be changing programs, which will probably change our reporting as well. But prior to us deciding we were going to change the system, we needed to figure out a way to include everybody, and this was what they came up with. So the results are based on your data exports. So they're only as up to date as the last export. And for every site, you are set up to have an automatic export on the 21st of each month. And then there's a few sites that have sort of large volume in their workload that also go on the 8th of the month. And that is not set up for everybody, just some of our larger sites. But the GIPR reports at the ITSIS data mart do utilize official user population. So that's where registering patients correctly, making sure their community of residence is correct, their beneficiary classification, their tribal membership, all of that plays a huge role into not just user population workload, but it also impacts GIPRA. So the GIPR year does follow the fiscal year. So it's October 1st to September 30th every year. I mentioned the exports for the non-RPMS sites. So the data is going to be based on the most current export. A couple of you do it every month. One of you does it on a more quarterly basis. So if you're not seeing changes in the reports, sometimes it's just a timing issue of when the reports were refreshed and when the last time data was sent. So we typically follow the timeline for workload and user population. And for this year, for 2021, the data needs to be exported to the data warehouse by October 21st. And I will tell you that for the RPMS EHR sites, it's really October 20th because the export will run on the 21st, but it grabs data from the day before. So you need to have your data clean, complete, everything for fiscal year 2021 as it relates to ambulatory visits and ambulatory information in the system ready to go by October 20th. For non-RPMS sites, you want to make sure that you send your set of files in for your last export by the 21st of October. Basically what happens is they will freeze the data, do some cleaning up. They will produce the workload reports, the user population reports, but the user population reports typically don't get populated until December. And so for GIPR data, any historical data that's coming through, you can actually submit that through November. So if you are still mining an immunization registry, you have an extra month to get that information in, but it only will count information that is between the October 1st, 2020 and September 30th, 2021 date. So some things that they're still trying to figure out. The shared Perk does. This has been a hot topic. It seems to affect our area most, or maybe I'm just the most vocal about it to our headquarters staff. They're still working on it. And they have told us that they're considering changing the platform for ITSIS reporting. And I think that when they do that, they'll be able to separate things out, but that has been a TBD. COVID has kind of put things on hold. And so that's still something that we continue to bring up. They are still trying to figure out how to break out the urban user population. So in the Nashville area, we have a couple urban locations that their service area overlaps with a federal or tribal entity. So they're trying to figure out how do we pull those people out without taking them away from somebody else. They have added in the service category for telemedicine at the data center, but the CRS logic has not yet been updated to include that. They're working on that in the next iteration of the CRS patch. The next patch will include telemedicine visits. Something that has also been brought up as a concern is the exclusion or inclusion of the public health emergency clinic code. So when the pandemic started, this code was created specific for public health. The way that it is in the standard code book, it is still included in user population. So patients that have only their one visit as a public health emergency visit are part of the denominators. And so the question is, should they be? If they only came in to get a COVID vaccine or get a COVID test, but they don't come in for other services, should we include them in the logic? So that's something that they're looking into as well. So locally, nothing changes for you. The CRS software will continue to be updated. There was a recent patch, I believe it came out about 3 weeks ago, maybe. And that'll be the final patch for 2021. The next patch for 2022 probably will not be available until February. So if you are trying to run reports to get a jump on your flu vaccine list, those types of things, you want to make sure that you are using the 2022 date as your end date. Because if you use 2021, you're going to pull up the people for this year and not next year. You want to make sure that you are still having your team meetings, running patient lists, using iCare or forecast reports to see who needs services. We've had to become a little bit more creative with some of our services with COVID because we're not seeing as many people. They're not coming in as much. We might be having to do more telehealth visits. So you might have to rework some of those processes to build in screenings for behavioral health, the alcohol, depression, domestic violence. You want to make sure that you have up-to-date policies and procedures. If you are doing a telemedicine visit and somebody screens positive for those, what's your next step? How are you going to refer them to care? Those are some things that you'll need to think about locally. The numbers that come from ITSIS, the national center, will be different than those produced locally. And that's mostly because of a timing issue of when the reports are run, when the data gets there. It could also be an issue of where people are registered and who's counting them for user population. So those are a few things that may come into play in terms of the data being different at both locations. So we'll continue to run CRS monthly reports. We do send those when ITSIS data is updated. We do share those as well. We have asked for them to be able to produce dashboards for service units. That's also something that's to be determined. But we are available, either myself or Brian, for one-on-one sessions related to assistance for GIPRA, improving your rates. If you're wanting to do anything related to a measure of the month, please reach out because we are here to help you. So I'm just going to run through some quick strategies for improvement. You want to make sure that you're entering medical data from outside sources. So if you are using PRC services, when you close your purchase orders, make sure that you are entering ICD-10 codes, CPT codes. If you are getting reports from outside providers, you want to make sure that you're entering that information into the system as well as historical data. Make sure the data is accurate and complete. Again, garbage in, garbage out. If it goes in incorrect, it's going to come out incorrect. So any services that are not done on site, you want to make sure that that gets entered as historical non-visit data into your system so you get credit for it. So if you are using the RPMS EHR, one of the handouts is just a cheat sheet for EHR users on kind of where things are in the system, how to document. There is a cheat sheet for non-RPMS users that just has those ADA codes, CPT codes, ICD-10 codes that can be utilized. They kind of look like this. There's also some instructions. We do have a few sites that are still not on EHR that are just using the roll and scroll RPMS. So there are some instructions for how to enter visits done on site, as well as historical for those locations as well. So I mentioned historical a few times, and it came up in one of my trainings that people didn't know what that meant. So essentially it's a service that's not done on site. It may have been paid through CHS. It may have been something that somebody came to you guys to establish care and they wanted to populate their record with information from a different provider. So those are the things that are considered historical or non-visit data, things that happened outside of your facility that you want to put into your system. It's important to make GIPRA a priority, and I know that this has been a tough year, and thank you to everybody who has still continued to work on GIPRA as a priority. But it did require some changes in workflow, some changes in the way that we do business, basically. So thank you guys for continuing to make it a priority. You want to look at your data on a regular basis. I mentioned early on the issue with the Dentrix data. That was identified by a site that was looking at their data, and they just said, this isn't right. It's not looking right. And so finally we were able to go in, figure out that the data was not getting ported to PCC correctly. So it is important that you guys at the sites look at your data. If it feels wrong, let us know, because we can look and see if there's anything weird in the system that we might be able to help troubleshoot. Because on our end, it might look great, but for you guys, you should be at 100%, and I'm saying 60 looks awesome. But that's because we don't know what's happening locally. So if it doesn't look right or if it feels wrong, let us know. It's important to use a team approach. This cannot be done by just a nurse, cannot be done by just a medical provider. It does include a whole team, again, including that patient registration staff. Could even include your business office staff, because if they happen to be changing ICD-10 codes or CPT codes based on documentation, you should probably have a conversation about that and see what's going on that might be causing a need to change that information. So it really is a team approach. You want to identify patients that need services. When they do come in, or when you do have those telehealth visits, provide all services that are applicable. Some of our sites have started to do some of those behavioral health screenings while they are giving COVID shots, because the patient has to wait 15 minutes. It's a great time to just screen them and see if they need any services. Other facilities have started to do callbacks when they're checking on those patients after they got their COVID shots, and at that time taking the opportunity to screen them as well. So there's a lot of creative ways that we can get patients in to meet these measures and get the services that they need. Some other things, sending out postcards, letters, inviting them to dental or medical clinics. Again, it's a tough time right now to do some of these on-site services, but those are things that maybe this time next year we can think about doing. Same with health fairs, community events. I know a lot of people had them planned for the end of the summer, had to cancel them. So we have to get creative again to make sure that these patients just are not sitting there, not getting preventive care when there might be a way we could provide it to them. And then you also want to make sure that you're following up on test results. So anything that's sent out of your system, reference lab links do break. So sometimes you might not be getting the results back. Also, if you're referring somebody out, make sure that you're getting that information back into your system. And that is the end of my slideshow. So I will stop sharing and then we can see if there's any questions.
Awesome. That was a great presentation. Thank you so much. If there's any questions, you can unmute yourself, or you can raise your hand and I can call on you, or you can put it in the chat box. You can privately send it to us too if you don't want to ask. Oh, there was a question in the chat box. I'm sorry.
So for I see the IPV one. Yeah, so for the IPV DV, so right now in our PMS, that's the only way that we can really kind of document that outside of using the ICD-10 codes. So for that one, you can use exam code 34. The agency is not currently tracking a result. We're just tracking if it was done. So for the intimate partner violence, domestic violence, it is okay to just use exam code 34. But for the depression and the alcohol, you need to use an additional screening or just the PHQ-2, 9, or T, or the CAGE, audit C, or CRAFT.